Welcome to the afternoon session of this Yale Center for Immuno-Oncology Symposium. This afternoon session, the first session, will focus on the tumor microenvironment, and we have three exceptional speakers in this session. So it's my pleasure to introduce the first speaker this afternoon, Dr. Jennifer Wargo, from the MD Anderson Cancer Center, where she's an associate professor in the Department of Genomic Medicine and Surgical Oncology. And Dr. Wargo has really, most recently, done some pioneering work to understand the role of the microbiome in the response of tumors to cancer immunotherapy. So it's great to have you here. Thank you very much for coming.
Thank you, Catherine, for the kind invitation. Thank you to the organizers for the invitation to come and speak today. It's an honor to be here at Yale, and thank you in advance for your attention. And I'm hoping I'll give you some insights into how we can use tissue-based analysis to gain insights into response and resistance to cancer therapy, as well as the role of the gut microbiome. And I promise I'll even give you some advice on what to eat for dinner tonight. So I do have a few disclosures. First, I just wanted to say it is great to be at Yale. I didn't even get an interview here for med school, but I did wind up going, just to give you my background, I wound up in med school in Philadelphia. I went to MGH for my surgical residency. How I got interested in immuno-oncology was during medical school, where I actually studied, first looked at immunosuppression in the setting of biliary obstruction and ligated bile ducts on rats for a living. And then when I was at MGH, got interested in taking care of patients with cancer, and so wanted to bring the two together. So first I worked with Tony Rebus at UCLA. I was actually his first postdoctoral fellow. And then I worked with Steve Rosenberg at the NIH, and also interviewed with Suzanne Topalian while I was there. After completing my surgical oncology fellowship, I went and was on faculty at MGH for several years, and then made the move to MD Anderson in 2013. But again, it's an honor to be here with the leaders really in immuno-oncology here at Yale. And so what I wanted to do is take you through a couple of vignettes on how we've come to better understand response and resistance to cancer therapy. And really we'll use melanoma as really a linchpin there. And so we certainly know that we've made major advances in the treatment of melanoma through the use of targeted therapy as well as immunotherapy, and we've now used this to translate it to other cancer types. And this slide just shows the approvals, FDA-approved agents for patients with stage 4 melanoma, and as of the year 2000, you can see that very few regimens were actually approved, and neither of these was horribly effective. But over the past 10 years, we've now had over 10 new regimens approved for our patients, which is really quite dramatic. And as Harriet and others here, and Pat LaRusso know very well, is that these advances have actually translated into huge advances for our patients, where we've doubled and now tripled the one-year survival rates for patients with stage 4 disease. And of course, these are now being used across other cancer types. And so, however, we know that despite these advances, responses to these different forms of cancer therapy are heterogeneous, and they're not always durable. And you can see this in these waterfall plots here, where each of these bars represents CT-based imaging and showing either a response or growth of tumors. And anything that falls below the 0 here means that the tumors responded or shrank on therapy. And you can see in the case of BRAF-targeted therapy, though the majority of patients actually have a response, they're not always durable. Same holds for PD-1 CTLA-4 monotherapy. Not all the patients respond to these, and there are a significant proportion of patients who don't respond. And then for combination, again, more responses, but you get issues with toxicity. And what I'd argue is there's still a critical need to better understand who's going to benefit from therapy, as well as proper timing, sequence, and combination of different regimens. And so how can we better understand responses to therapy and actually optimize these treatment regimens? And I've been in the lab now 10 years, had my own lab 10 years, and have been studying this full force with many others. And a powerful way to do this is to actually use a process called reverse translation, one where we've really focused on, and that's taking samples from patients who are going on to treatment, getting longitudinal tissue and blood samples in the context of therapy, deeply profiling those and then learning from those tissues, bringing it back to mouse models, and then doing mechanistic studies and therapeutic optimization studies in those models, and then finally bringing these insights gained back to our patients. And I'll show you some examples of that. And so now we definitely know that responses to various forms of cancer therapy are dependent on a number of factors that shape tumor growth and immunity. And we've learned from Ellie and others that the tumor genome and epigenome are critically important. But again, as Richard Flavelle pointed out, the tumor microenvironment is also very critical in this. And as we know with cancer immunotherapy, the immune system plays a major role. But now, in the latter half of the talk, what we'll really discuss is that environmental factors can actually play a dramatic role in how patients respond to cancer therapy, one of these being the microbiome. Furthermore, these are all tightly interrelated. Now, so the first part of my talk is the tissue is the issue, and this was a quote from Patrick who is a current mentor of mine at MD Anderson. And when I first joined MD Anderson, he kind of posed me with this challenge and really wanted me to come and build a program to analyze tumors from patients to gain better insight into response and resistance to cancer therapy. And so I'll tell you a little bit about that. Now, the first insights that I gained, however, were during my tenure at Harvard when I had just finished training with Steve Rosenberg and was recruited to come back and start a program for adoptive cell therapy. Came back to Mass General, was all ready to set things up, and at the time, immunotherapy wasn't working, and targeted therapy had come center stage. And so they were like, well, Jen, that's great, but you know what? We've really shifted our focus. You may want to reconsider, what you study. And so instead of throwing out the notion that immunotherapy would work, what we wanted to do was to better understand the impact of oncogenic mutations on anti-tumor immunity. Now, we know that oncogenic mutations in the BRAF gene occur in over half of patients with melanoma, and that this mutation can actually be targeted therapeutically. And you can see this here, where if you actually give patients a pill once or twice a day, you can actually improve their survival over then standard of care dacarbazine or chemotherapy. And this was the basis for the FDA approval of these agents as monotherapy in 2011. And now these agents, including single agent as well as BRAF and MEK inhibitors, are actually now being used in the adjuvant setting after patients have resection of high-risk metastatic disease like stage 3 disease, with very nice results, showing that if patients who have a BRAF mutation in their tumor have surgery and then are treated with a BRAF and MEK inhibitor in the adjuvant setting, they actually have significantly prolonged survival, and the number of zeros on this p-value is pretty astounding. But this is great. However, we know that the majority of patients, at least in the setting of stage 4 disease, who are treated with BRAF and MEK targeted therapy progress, and that we still need critical insights into how we can better optimize responses. And so again, when I was just starting out at Harvard, these patients were just starting to be treated on clinical trials. I teamed up with Keith Flaherty and Levi Garraway and others to really try and understand the mechanisms through which these BRAF inhibitors were working in patients. And so what we did is we turned to our patients to really best understand this. And so this is how we did it. So anytime patients came in, we enrolled them onto tissue acquisition and use trials. If they were going on to these targeted therapy agents, we would get a biopsy and a blood draw before treatment, start their therapy, get an early on treatment biopsy and blood draw, which actually turns out to be quite critical. And then they would be restaged, treated per standard of care, and then we would get a blood draw and biopsy at time of tumor progression, if applicable. And what we did with these tumors is we actually deeply profiled these from a molecular standpoint as well as an immune standpoint. And really, to summarize the work of many people worldwide, and a couple of years' worth of work, is we basically identified multiple molecular mechanisms of therapeutic resistance that could actually be targeted in these patients. And in addition to that, we know that these oncogenic mutations can actually make tumors evade the immune system. And we hypothesized that if you block these oncogenic mutations, you could make tumors more immunogenic. And so we studied this in patients, and what we found is that we looked before treatment with BRAF targeted therapy, and we found that patients actually had a very low melanoma antigen expression and very few infiltrating CD8 T cells. But within 2 weeks of starting a BRAF inhibitor or MEK inhibitor, what we found is that there was this dense and dramatic increase in the infiltrate of CD8-positive T cells, also with an increase in antigen expression, which really provides an immune mechanism of response to these targeted agents, saying it's not just working based on pure cell kill, but it's actually invoking an immune response. However, in addition to, at the same time, you're getting all these T cells rushing into the tumor, you're also getting upregulation of PD-L1 in the tumor microenvironment, suggesting a mechanism of adaptive resistance to this otherwise very effective form of therapy. But what this did provide us, and especially with the great work of Suzanne Topalian and Li-Ping Chen and others, was really to provide the rationale for combining these strategies. Not just say, okay, we're going to use targeted therapy or immunotherapy, but how about if we can use these together? Is there a real strong scientific rationale to do so? And so we went back to mouse models with Arlene Sharp, and basically we showed that the addition of immune checkpoint blockade to a backbone of targeted therapy enhanced immune infiltrates in these mouse models. I show you data that Zach Cooper generated, where he showed that in mice treated with a BRAF inhibitor alone, there's a modest, really negligible CD8 T cell infiltrate. But if you combine both BRAF targeted therapy as well as targeting PD-1 within these mice, what you get is a dramatic increase in tumor CD8 positive T cell infiltrate, which is associated with prolonged survival and slower tumor outgrowth. And now multiple trials are actually underway that are combining targeted therapy and immune checkpoint blockade, and this is happening not only in melanoma, but also in other tumor types. And so a real paradigm shift saying, okay, can you actually use targeted therapy along with immunotherapy to make this work better? Now that's just giving you a little bit of a story on BRAF. I know it's, well, I would say it's immunotherapy, but now let's kind of shift our attention to something else. And so that's certainly focusing on some of the genomic components. How about the role of tumor stroma? And so we also, with other groups at MIT and the Broad, we started looking at the role of tumor stroma, and I'll tell you a little bit about how we studied that, and then how it serendipitously led us to study the role of the tumor microbiome. So now, when we were studying patients with melanoma, we worked with Todd Golub and Ravid Straussman at the Broad, and we wanted to use a model system to better understand stromal-mediated resistance in melanoma. And again, as Dr. Flavelle pointed out, this tumor microenvironment or tumor stroma is actually critically important. And can we actually identify a potential role for stroma in mediating therapeutic resistance? And so what Todd and Ravid did is they developed this 3D culture system where they co-cultured cancer cell lines, in this case melanoma, along with stromal cell lines, and then drug, in this case BRAF inhibitors. And they then tested to see if any of the stromal cell lines could mediate therapeutic resistance. And what they found when they did this is they found that there was a number of different stromal cell lines that were actually able to mediate therapeutic resistance to BRAF-targeted therapy. And what they found after testing these is that these stromal cell lines were actually secreting hepatocyte growth factor. Now, being a surgeon scientist, I was able to go back to our patients along with Keith Flaherty, do tumor biopsies in these patients and look at expression of HGF within tumors of these treated patients. And lo and behold, what we found is that if patients had HGF within their tumor microenvironment, they were far less likely to respond to treatment with BRAF inhibitors. And Ravid and Todd published these findings in Nature in 2012, and now there are efforts underway to combine these strategies. So here's where the twist comes in. And so we also, after using this model system to study melanoma, Ravid and Todd also wanted to look at different types of cancer. And so they focused on colorectal cancer and also on pancreatic cancer. And while I was at Mass General, I was doing surgery for both patients with pancreatic cancer as well as for patients with melanoma. So I was doing wide excisions and Whipples, and I was able to contribute to some of this research here. And so again, they used this 3D culture system where they co-cultured cancer cell lines, in this case, either colorectal cancer or pancreatic cancer cell lines, along with stromal cell lines and along with drugs. And in this case, they were focusing on resistance to chemo. And what they found when they did this is they found something really striking, namely that there was one stromal cell line that was consistently able to confer resistance to multiple tumor types against resistance to chemotherapy. And so they did a lot of studies, showed that this was a secreted factor. We scoured human tissues for different enzymes that could be responsible for this, came up totally dry after about a couple of months or a year of work. And then on routine testing of the cell line in the lab, what they found is that it was actually contaminated with mycoplasma, which at first was a bit deflating, but Ravid was brilliant, because what Ravid said is, well, wait a second, what if this mycoplasma is actually contributing to the therapeutic resistance? And so what he found is that the mycoplasma was actually responsible for the resistance to gemcitabine. He found that if he eradicated the mycoplasma from the cell line, it no longer conferred rescue. If he infected another cell line, it conferred rescue. And then he did whole genome shotgun sequencing of the HDF preconditioned media, along with Curtis Huttenhauer and others at Harvard, and showed that this indeed contained mycoplasma. And what he found is that bacteria were actually breaking down gemcitabine into its inactive form. And so again, Ravid and Todd turned to us. I was able to help out, and what I did is, when we were taking patients to the operating room to do pancreatic resections, I would harvest tumors sterilely in the operating room from patients either with pancreatic cancer, or if we were doing surgery for non-cancer indications such as chronic pancreatitis. We were able to take this back to the lab and actually plate it out, and we saw night and day differences. It was striking. We actually found that if you plated out these tumor digests from patients with PDAC, you actually had very dense bacterial growth on the agar plates overnight, whereas if for non-cancer indications like pancreatitis, none of the patients had these bacterial colonies grow out. They looked at this via a number of different means, including by sequencing and also by visualizing these bacteria within tumors. And they found that, lo and behold, within 75% of patients with pancreatic cancer, you could actually identify bacteria within the tumors that were able to break down gemcitabine. They worked with Curtis and others at Harvard to actually characterize these bacteria, found that these were gamma proteobacteria, and then turned to the mouse model, actually showing that if you co-target the bacteria within the tumors by treating with antibiotics and treat with chemotherapy, you could actually eradicate these tumors. And they published these findings in Science about a year ago. And so pretty interesting. And so we got very interested in the tumor microbiome at that point, and really started studying this in melanoma and other cancers. And I'll get back to that story. But first, I also wanted to touch a little bit on biomarkers of response to immunotherapy for melanoma. Certainly that's one of the focuses of today's conference. And we've already heard some wonderful data from Ellie and others about the utility and some limitations of some of these biomarkers. And so we know through the outstanding work of Ellie and Tim Chan and others that biomarkers of response to immune checkpoint blockade have been identified but are not perfectly predictive. This is including data from Li-Ping Chen and others showing, and Suzanne of course, that showing that, yes, mutational load, and Ellie pointed this out himself, yes, patients who have a higher mutational burden tend to have better long-term benefit from these agents. However, what you see is that there's a high degree of overlap. Yes, it's statistically significant, but it's highly overlapping, and you can't necessarily pick with real conviction a set point at which you could say, okay, above this mutational burden, this patient's definitely going to respond, and below this, someone's not going to respond. In addition to this, Tony Rebus and others have shown that baseline CD8, and actually not just the density, but the distribution of these CD8 T cells being at the margin of the tumor, at the invasive margin, can be predictive. But again, it's difficult to measure in core tumor biopsies and other strategies, and it's also not perfectly predictive. PD-L1 we know is really a good marker. Again, not perfect, as well as these T-cell inflamed versus non-inflamed tumors. Again, highlighting, I don't think we have a single biomarker that's perfectly predictive that we can really hang our hat on yet. And so we wanted to build on these studies, and this was work done at MD Anderson with Jim Allison and Pam Sharma. And what we wanted to do was to really build on these studies to better understand potential predictors of response to immune checkpoint blockade. And so to do this, what we did is we assembled a cohort of patients, just over 50 patients, who were treated first with CTLA-4 blockade. And you can see the proportion of responders and non-responders here. And those who progressed or failed to respond on CTLA-4 blockade were treated on PD-1 blockade. And again, you can see the proportion of responders and non-responders. It was just pretty much in line with published literature. So what we did with this cohort is we went back and scoured the pathology lab. We had performed some biopsies on prospectively collected samples, and we also got archival tissue from retrospective biopsies, and got biopsies at pre-treatment CTLA-4, early on treatment, with CTLA-4, at time of progression on CTLA-4, which also served as a pretreatment PD-1 biopsy for these patients, on treatment PD-1, and then at time of progression on PD-1. And what we did was deep molecular and immune profiling to try and gain insight into potential mechanisms of therapeutic resistance as well as biomarkers. And this is all published data, so I won't really go deeply into it, but what I wanted to really highlight is that what we found pretty much right off the bat was that immune signatures, when we looked at them, in pretreatment biopsies largely failed to predict therapeutic response. And this is something we've seen as a field, not only in melanoma, but in other cancers. And so again, just like mutational load, yes, can you actually see significant differences, that have a significant p-value between responders and non-responders with regard to CD3, CD8, some other markers? Yes, you can. But what I can tell you also is, just like TMB, there's a lot of overlap here, and you can't necessarily pick a set point and say, okay, this patient is going to respond if I treat them with PD-1. And this we saw with the 12-marker IHC panel. Interestingly, with the 800-gene nanostring panel, we saw the same thing, as we didn't find any pretreatment predictive biomarkers that really had good significance. But if you simply give a dose or two of anti-PD-1 and then do an on-treatment biopsy and look within the tumor microenvironment, what you see is quite striking. Namely, that these signatures in on-treatment biopsies were highly predictive of response to checkpoint blockade. This shows that data. Again, this is the 12-marker IHC panel, but the data for the nanostring panel is even more beautiful. And what we found is that you could tell, definitely with conviction, whether or not a patient was going to respond or not to treatment, but just by looking at adaptive immune signatures early on treatment. This is histology, just to drive that fact home. I can tell you the pretreatment samples look pretty much, both of them looked like non-responders. I couldn't tell. If you gave me, money, I wouldn't be able to tell you which patient was going to respond. But if you simply give a dose or two of anti-PD-1 and then look at an early on treatment biopsy, again, you find very distinct differences between responders and non-responders. And what this suggests to me is that we could actually have some pretty decent biomarkers at present, but we're simply looking at the wrong time point. Again, we're kind of searching for the holy grail of the pretreatment biomarker over in these shallow, devoid waters, when really all we need to do is stress the system and look at an adaptive immune response early on treatment, and we'll have our answer. And I would suggest that perhaps rather than putting an emphasis on these pretreatment markers, for checkpoint, we should be looking at adaptive immune responses in early on treatment biopsies, at least until we identify better pretreatment biomarkers. Now, what I can tell you is we're trying to do is taking those patients who had an early on treatment biopsy and had a brisk immune infiltrate, going back to their pretreatment samples and trying to identify what in the pretreatment sample might predict that, but I don't have the answer yet. I wish I did. So now, in addition to looking at these cohorts of patients that were retrospective and prospectively collected, what we've come to do a lot of these days is now we've really launched an effort to look at studying responses to cancer therapy in neoadjuvant window trials, and this has certainly been utilized in other cancer types, and we've now that we have some nice effective therapies in melanoma, we've been using it in melanoma as well. And again, I show you data. This is in the time for the adjuvant setting. We now know that, yes, these agents are effective in stage 4. They're also very effective in the adjuvant setting. And this is data both for targeted therapy as well as checkpoint blockade. Now, we know that there's a very strong rationale to use this in the neoadjuvant setting, i.e. before surgery. And why is this? Well, we know that for patients who come in with bulky stage 3 disease, like this patient who has bulky lymph node disease in the groin or in the axilla over here with this patient, we know that currently upfront surgery is the standard care for these patients. So they come into a surgeon's office almost anywhere in the country, not mine, but they'll be taken right to surgery. But we know that if patients are treated in this manner, up to 70% of those patients will relapse and potentially die of disease. So that's the clinical rationale. Now, in addition to this, there's a very strong scientific rationale. And there's a paper published in Cancer Discovery 2 or 3 years ago, which basically showed that in preclinical models, and this is in breast cancer, actually suggested improved outcomes in neoadjuvant versus adjuvant treatment using immunotherapy. And in this setting, what they did is they treated with either PD-1 combo in the neoadjuvant versus adjuvant setting, and they showed that this was an antigen-specific T-cell response. So we did 2 studies recently to kind of test the hypothesis that using these agents in earlier stage disease, i.e. in the neoadjuvant setting, would be highly effective. And the first of this was in a targeted therapy population. And so what we did is we first ran a trial, doing a phase 2 trial to test the hypothesis that if we treated with neoadjuvant and adjuvant BRAF and MEK inhibitors, it would improve relapse-free survival over standard of care upfront surgery, kind of saying right off the bat, should we be doing surgery on these patients or should they be treated in a neoadjuvant approach? So this is the design of the trial. We took patients with stage 3B, 3C melanoma who harbored a BRAF mutation in their tumors, and then randomized them in a 1-to-2 ratio to either get upfront standard of care surgery versus treatment with neoadjuvant and adjuvant BRAF and MEK inhibitors for 8 weeks. This group would get restaged, have surgery, and then go on to adjuvant therapy. Now, what we also did in these studies is we collected biopsy specimens. Now, the beauty of a neoadjuvant approach is you're guaranteed to get this. This is pretty critical to get, if you ask me, as a baseline tumor biopsy. And you can also get early on treatment biopsies. That's something that we've become very keen on looking at because it does give us a lot of insight. But basically, we got blood draw tumor biopsy before treatment, early on treatment, at time of surgery, and you get a nice big tumor sample here. We also got blood every 3 months with restaging, and then blood and tumor at time of relapse, and did similar studies on these tumors and blood samples. Now, interestingly, what we found when we ran this trial is that we actually had to close this early by the DSMB because at the time of first data cut, really all the patients who had gone into standard care upfront surgery relapsed. Several patients died. And then at the time of first data cut, again, all the patients who had been treated with neoadjuvant therapy had not relapsed. Now, subsequently, some of them did, and I'll show you that data. But basically, we closed this trial early. And we were able to analyze the results. So, and what we found is that treatment with neoadjuvant BRAF and MEK inhibitors was associated with a high RECIST response rate. No great surprise there. It's pretty much mimics what we see in stage 4, where patients had an 85% RECIST response rate. So you can see that the majority of patients had their tumors shrink. But what was really provocative is that over half of patients, 58% of patients, after 8 weeks of treatment with neoadjuvant therapy, and these are patients with bulky disease, had no viable tumor, okay? So 58% pass CR rate. And not surprisingly, but very profoundly, what we saw is that patients who were treated with neoadjuvant BRAF and MEK inhibitors, if they had bulky disease and a BRAF mutation, had much better survival compared to those patients who went to standard of care upfront surgery, okay? Bit of a no-brainer study, but I think it had to be done. And then importantly, though, when we looked at patients who had a path CR versus those who did not have a path CR, what we found is that if patients had a path CR after 8 weeks of therapy, they had a 100% survival rate, whereas if they failed to achieve a path CR, their survival was quite poor. So we turned back to the tumors in these patients, and what we found, we looked from a molecular standpoint, and we found that in baseline samples, we actually found that patients who failed to achieve a path CR had a higher frequency of known resistance-conferring mutations that activate MAP kinase. And in addition to that, we also found immune mechanisms of resistance. Namely, though they had equal numbers of T cells at baseline between those who achieved a path CR versus those who didn't, patients who failed to achieve a path CR, their T cells were completely exhausted with high expression of LAG3, TIM3. And we actually have targets for this. In addition to this, we found that patients who failed to achieve a path CR had no change in their tumor microenvironment to baseline and early on treatment, whereas all the patients who achieved a path CR had a delta. They essentially went from a cold tumor microenvironment to a hot tumor microenvironment, again, suggesting that these early on treatment biopsies may be helpful even in the setting of targeted therapy. Now, another interesting tidbit of unpublished data is that we looked back and we did gene expression profiling on these tumors, and when the analyst was going over the data with me on the phone, she was like, "Hey, Jen, did you realize that all the patients who achieved a path CR were female?" And I was like, huh. So I was intrigued by this, right? And I actually couldn't sleep that night. So at first I was like, small cohort, we can't get too excited. But I couldn't sleep, went back to the EMR, looked at an off-protocol treated population, same thing. We've now opened the study as a single-arm trial. We see the same exact thing. And what we think this is both a tumor intrinsic and extrinsic mechanism largely on estrogen signaling, but we've now taken female cell lines, put them into either male or female mice, treated with dabrafenib and trametinib, and lo and behold, the females do better. And so now we actually have therapeutic targets for this that we're working up, and Miles Andrews is going to be presenting this at SMR in a few weeks, so stay tuned. But showing kind of, and there was a recent JCO article on this, is looking at gender-specific responses to different cancer therapies. So Now, in addition, so back to immunotherapy, in addition to running this neoadjuvant targeted therapy trial, we also ran a phase 2 trial looking at neoadjuvant and adjuvant checkpoint blockade in patients with bulky stage 3 melanoma. Similar population, this time they either did or didn't have a BRAF mutation, but did not have prior checkpoint, and we excluded patients with brain mets. And this time randomized them not. No one got standard of care upfront surgery, but they either got treatment with Ipi-Nivo or combined CTLA-4 and PD-1 blockade versus PD-1 blockade alone. After about 9 weeks of therapy, they got restaged, had surgery, went on to adjuvant PD-1, and again, what we found, well, we did, of course, lots of heavy-duty correlative studies on longitudinal biopsies, and what we found again is that there were very strong signals in this trial, which the DSMB closed this one early as well, and mainly because of efficacy in one arm and toxicity in the other, and you could probably guess which ones, but I'll go over the data. And so what we found in this study is that treatment with neoadjuvant Ipi-Nivo, or CTLA-4 and PD-1 blockade, was associated with a higher RECIST response rate and a pass CR rate, and improved relapse-free survival over Nivo monotherapy. And I remember actually Suzanne Topalian was down at MD Anderson as we were designing this trial, and I had asked her, and she was like, "Oh, Jen, I'd worry about PD-1 mono in these patients," and it was appropriate. What we found is that they only had a 25% RECIST response rate and only a 25% pass CR rate. And actually there were 2 patients, 17% in a small cohort, of course, who actually progressed on therapy to the point where they did not undergo surgery. Now, conversely, the patients who got Ipi-Nivo had a 73% response rate, so triple their RECIST response rate and nearly double their pass CR rate. And again, numbers are low, so take it with a grain of salt, but when you look at these patients treated with combined checkpoint blockade targeting CTLA-4 and PD-1 versus PD-1 blockade alone, you can see low numbers, not statistically significant, but there appears to be a signal here. What this begs for is more trials. Now, what's the hitch? Well, with combination therapy, as we know from treating stage 4 and also treating other tumor types, we know that toxicity can be a real issue with Ipi-Nivo. And so we saw that 8% with Nivo mono, and with combined CTLA-4 blockade and PD-1 blockade, it was 73%. So this was, and there were patients with colitis who were on steroids, patients who became diabetic. So it's no small issue here with the toxicity. So now we did do correlative analyses on this trial from this neoadjuvant trial, which revealed both known and novel biomarkers and targets for therapeutic resistance. Reassuringly, we found that baseline CD8 count was modestly predictive, didn't even hit significance here in this small cohort. Early on treatment biopsies, reassuringly again, were highly predictive of response to immune checkpoint, either for monotherapy or for combo. And then we found that cold tumors were less likely to respond to either nivolumab monotherapy or to combo therapy. So we know all that from the monotherapy setting. But what was interesting is that when we used the nanostring DSP technology and looked at differential gene expression, or differential expression rather, in responders versus non-responders in baseline and on-treatment samples, and what popped up, which was interesting and different, was we actually saw B-cell markers. And so we also saw this in transcriptome data. We went back to the tissues, and lo and behold, in responders to either single agent or combo at baseline, but more profoundly early on treatment, we saw B cells, the presence of decent number of B cells in the setting of tertiary lymphoid structures, which is provocative. And I can tell you that other people are seeing this across tumor types. So now we are working with others to better understand the implications of these findings and to inform next steps. This includes with Christian Blank and Ton Schumacher, who ran a similar trial. This time it was a neoadjuvant versus adjuvant combo therapy, Ipi-Nivo. And what they found, similar to those mouse studies that I showed you earlier, is that if these patients receive neoadjuvant checkpoint blockade with combo checkpoint blockade, they actually have a higher number of tumor-resident TCRs that are expanded in the peripheral blood, suggesting that there's an enhanced immune response in the neoadjuvant versus the adjuvant setting. And we're actually working with others globally to form an international neoadjuvant melanoma consortia. There will be a meeting at ESMO in a few weeks and another one at AACR, so stay tuned. Would love to have people involved. Now, that's the tissue is the issue. How about the scoop is in the poop? So I'll give you a little insight into the microbiome. And so we certainly have studied the role of the gut microbiome in response to immune checkpoint blockade. And again, just highlighting the fact that, yes, we know all of these other factors are important, and they don't pale in comparison, but the role of the environment is actually critically important. And we know in our bodies we have over 100 trillion microbes. Their largest proportion of these are in the gut, and they're implicated in a large number of diseases now, from Alzheimer's to autism to even just common allergies. And now there's actually strong evidence that bacteria in the gut can actually influence responses to cancer therapy, and particularly to immunotherapy. What's the data? Well, there's data published several years ago from Memorial Sloan Kettering, which showed in a group of patients with AML who were going on to stem cell transplant, what they did is they profiled the gut microbiome of these patients, got fecal samples, did 16S sequencing. It was Eric Paymer and Marcel Vandenbrink and others. And they looked at first the diversity of the gut microbiome in these patients. And what they found is that if patients had a more diverse gut microbiome, they actually did better on therapy. They had better long-term survival. Now, in addition to this, I think we're all familiar with the landmark studies published by Laurent Zipvogel and Tom Gajewski in Science in 2015, which showed that the composition of the gut microbiota also seems to matter. And what they showed is, again, in preclinical models, that depending on which bacteria were in the gut of these mice, they either responded or failed to respond to either CTLA-4 or PD-1 blockade. And that furthermore, you can actually change the microbiome and make these mice respond better. And so we were inspired by this data, and so I saw this data presented, ran home to MD Anderson, and actually started a protocol to collect gut and oral microbiome samples in patients with metastatic melanoma going on to systemic therapy. Deepak Kapalakrishnan, who was a grad student, now postdoc in the lab, really pioneered this. And what we did is that when we had patients coming in, we would enroll them onto our protocol, collect an initial oral and gut microbiome sample, do a tumor biopsy when possible, start therapy, restage, and then repeat. Now, this is the cohort, so we did this right in the clinic where we basically, when patients came in, we would swab their cheek, 100% compliance on that. All 233 patients didn't object to that. For the fecal microbiome samples or gut microbiome samples, we actually handed them a kit so they could take it home and in the privacy of their own home collect their gut microbiome sample, and about half of patients mailed that back to us. Now, you can see concurrent landscape, or consistent with the landscape. Most of the patients were treated on checkpoint blockade, either combo or single agent. And we focused on PD-1 first, as this was the largest proportion of patients. And so I'll just show two slides, because I know many people have already seen this data. But basically what we did is we collected these samples and then sequenced the microbiome both in the mouth and in the gut. And what we found right off the bat is that we found that responders to anti-PD-1 based therapy had a higher diversity of bacteria in the gut microbiome, much like they had seen in the settings of stem cell transplant. We also broke this down into tertiles of diversity, characterizing patients as either having a high, intermediate, or low diversity in the gut, just as Eric Paymer did, saw the same exact thing. So patients who had a high diversity of bacteria within the gut microbiome had prolonged progression-free survival on anti-PD-1. In addition to this, we also saw compositional differences, where patients who responded to anti-PD-1 had a higher abundance of specific bacterial taxa in the gut microbiome. And it was a group of taxa, not just one, but more like Clostridiales, Ruminococcus fecali bacteria, the so-called spore formers. And then non-responders had a higher abundance of bacteria like Bacteroideales. Now, in addition to this, we actually were able to look at our patients and identify a signature within the gut microbiome, which was highly predictive of response to checkpoint. We found that about quarter to a third of patients had this so-called type 1 signature, which was characterized by a high abundance of this Clostridiales and a low abundance of Bacteroideales. And if you look at this type 1 signature, it was 100% responders. Now, we've now gone back and added 69 patients to this original 43. The signature's still there. It's not quite as pretty as it was for this, but it's still there. And so this does suggest that the gut microbiome could be used as a biomarker of response to checkpoint, with patients with a type 1 signature more likely to respond. And it was actually outperformed many of the other biomarkers. Now, what we saw is that these favorable signatures in the gut microbiome were actually associated with an enhanced immune response. So we just did a very simple study first and looked at CD8 counts in responders, non-responders. No shocker here, you saw that responders had a higher density of CD8s in the tumor microenvironment. But when we compared the bacterial taxa in the gut to expression of cytolytic T cell markers in the tumor microenvironment, what we found is that if patients had a favorable gut microbiome with the high abundance of these bugs, Clostridiales, Ruminococcus fecali, they had a high expression of cytolytic T cell markers within the tumor microenvironment. And the converse was true if they had an unfavorable microbiome. saw the same thing in the blood. They had more effector T cells and fewer Tregs if they had a favorable microbiome. Again, we love the mouse models. We turned back to our mice and we actually took fecal samples from either patients who responded to anti-PD-1 versus those who failed to respond, performed an FMT or a fecal microbiota transplant into germ-free mice, and then implanted melanoma tumors. And what we found is that if mice received a fecal transplant from a non-responding patient, the tumors grew rapidly and failed to respond to treatment with checkpoint. Whereas if they received a fecal transplant from a responding patient, the tumors either didn't grow at all or grew slowly and responded brilliantly to checkpoint. Now, other people have also looked at this. Tom Gajewski and Laurent Zipfogel also had cohorts. Tom, one of melanoma, Laurent had one with renal cell cancer, and lung cancer patients saw very similar profiles within the gut microbiome. And now numerous studies have been published showing a link to the gut microbiome in response, as well as toxicity to different forms of immunotherapy. But the taxa that are associated with responders differ across the cohorts, which is in part related to different approaches for profiling. And what I do think is, again, there's a real need to standardize the approaches. And Laurence and I are going to be running a SITC biomarker section just to look at that. Now, in addition to this, the question is posed, can we actually modulate the gut microbiome to enhance responses to therapy? And I would say it's a resounding yes. We're going to be working with the Parker Institute for Cancer Immunotherapy and a company, Series Therapeutics, to run a clinical trial to test the hypothesis. Now, this is the design of that trial. Key leaders, so there's 2 PIs at MD Anderson, Hussein Taubi and Bella Glitza. Teresa Lavalle at Parker Institute, and then Liz Burton at MD Anderson are key drivers too. But basically what we're going to be doing is taking patients with metastatic melanoma who are going on to immune checkpoint blockade, treatment naive in this case, and randomizing them to either undergo treatment with fecal transplant from complete responder patients. A third of patients will go into that arm versus a live bacterial product, which is a spore prep of around, it's about 50 in the consortia, versus placebo. And we'll be restaging patients' primary endpoint safety tolerability with additional secondary endpoints, including engraftment, as well as response, correlative studies on tumor and blood, as well as fecal samples, obviously. Now, interestingly, we do have data that suggests that these approaches could be helpful in treating immunotherapy-related toxicity. And so we've now treated several patients who had checkpoint-associated colitis. This is one of those patients who was treated with CTLA-4 and PD-1, developed riparoin colitis, which was refractory to both steroids and anti-TNF, had a single dose of FMT by colonoscopy, and her clinical symptoms totally resolved. Here's her colonoscopy images where you can see she has pretty significant inflammation at diagnosis. Even after steroids, the inflammation's even worse. And then after a single dose of FMT, you actually get complete resolution. And I can tell you that we've now studied a number of these patients. They're profoundly dysbiotic, and so very much like C. diff, IBD, these patients do seem to respond to FMT from a healthy donor. This was just from a healthy donor. Now, what we did is we did biopsies of the colon here, and we found that there was inflammation not only before the FMT, but there was still inflammation after the FMT. But when we actually looked at the type of T cells that were infiltrating the colon, we found that it went from a CD8 dominant to a CD4 FOXP3 dominant infiltrate, suggesting that this FMT was associated with recruitment potentially of Tregs to the colon, which could have helped with the resolution of symptoms. So finally, one last tidbit to help you decide what to eat for dinner. What other factors influence the microbiome that we could modulate and or monitor, that we definitely need to monitor? So interestingly, in Laurent Zitvogel's human cohort, what she found is if patients received antibiotics just before or just after starting treatment with checkpoint, they actually had worse survival. Now, we looked at this in our own cohort, and we found that if patients had antibiotics, they had a lower diversity in their microbiome, which in our hands, in prior studies, was associated with worse response. And we know that other medications can also do this. Now, in addition to this, diet can be important, right? And so in all of our patients, we actually did dietary surveys of those patients coming in. And what we found when we looked at the data is that patients who had a high fiber diet had a higher diversity of bacteria within the gut microbiome and more of these favorable gut bacteria. And Carrie Daniel McDougall and Jen McQuaid are doing this. We actually recently went back and found that patients who met the the fiber requirements had a 4-fold increased likelihood of responding to anti-PD-1. Now, how about probiotics? Well, now an unintended consequence, like Ellie's, I have these things that keep me up at night. So unintended consequences of publishing these papers is that now patients want to modulate their microbiome, and they're asking us which probiotic to take, not if they should take probiotics. And what we found is that if patients take probiotics, their gut microbiome is worse, right? So it's lower diversity, less likely to respond to therapy. And this is really important. And this kind of there were 2 papers published in Cell September 6th, which also show deleterious effects of probiotics. So all this has been done in the context of the Moonshot program at MD Anderson, but amazing studies are being done here and elsewhere, and really the strongest gains are made through collaboration, and it would be an honor to collaborate with you. So with that, I will close and take any questions potentially, if there's time.